Hello friends, this is Dr. Nikita here, your radiology educator. And now we are going to dive into rapid revision of radiology. So whatever is important and must know for the exam has been covered in rapid revision. In more details, it has been covered in the main videos. So if you are short of time, you can stick to rapid revision. So starting with the basics, the black and white of radiology. So what are the types of radiation? Now the types of radiation are ionizing radiation and non-ionizing radiation. Which is bad? Of course, the ionizing radiation, because ionizing means that it causes ionization, generation of free radicals and DNA damage. So in the types of ionizing radiation, we have electromagnetic radiation and particulate radiation. Electromagnetic radiation examples are X-rays, gamma rays. These are electromagnetic, like similar to light, these are electromagnetic radiation. And remember that a common feature to all the electromagnetic radiation is that they have the same speed at which they travel. The wavelength, frequency, energy is different, but the speed is the same. Particulate radiation includes the alpha particles, the beta particles, and the neutrons. Now, if I ask you that out of this radiation, which is the one which does not come from the atom or the nucleus disintegration? Remember, it is X-rays. So, radioactive atoms, radioactive isotopes do not produce X-rays. X-rays are extranuclear in production. Gamma rays come from the nuclear disintegration. Example of non-ionizing radiation is radio waves, which are used in MRI. So MRI does not have radiation exposure. Now, if I talk about out of these radiation, which is the one which is the most damaging? So remember that alpha particles are the ones which are the most damaging and they have the least penetration. So for penetration, alpha has least penetration but maximum damage. So less penetration but maximum damage. You can remember it as alpha particles, they do not penetrate the body. So what happens? They stay in the body and they have a good enough time to stay in the body and cause damage to the body. On the other hand, gamma has maximum penetration and it has the least damage to the body. Even more than gamma, if something which has more penetration, it is neutrons which have more penetrating power as compared to the gamma radiation. Now, in which investigations do we have no radiation? That means these are the investigations that we would prefer in a child, in a pregnant female, where we are very cautious of, exposing the patient to radiation. So, ultrasound, because it uses the sound waves, not any radiation. So, similarly, Doppler, which is ultrasound, fast, that is a focused assessment. This is not abdominal sonography. Remember that FAST stands for focused assessment with sonography for trauma. So remember that FAST is also sonography. So there is no radiation exposure. In FAST, basically we do FAST in any patient of blunt abdominal trauma to look for the presence of free fluid. If it is present, it is taken as there is some bleeding happening from some organ. So in that case, if the patient is stable, then the next step we do is CT scan, detailed evaluation with CT. If the patient is unstable, then we don't have time for further evaluation and we take the patient for surgery. So fluid can be very well seen on ultrasound. So FAST is done for quick assessment in a patient of trauma. MRI we said does not have radiation exposure. So similarly, MRCP does not have radiation exposure. Another investigation is thermography, which has no radiation exposure. X-rays, a CT scan, a fluoroscopy, DSA, all the contrast X-rays, IVP, HSD, MCU, RGU, all of them have radiation exposure. So what are the principles of the various modalities? Now, X-ray or radiograph, the contrast, the black and white contrast that we see, it's basically based on photoelectric effect. And remember that versus the Compton effect is the one which generates the scatter radiation, which is scattered from the patient's body. So the surrounding people can get radiation exposure, and that's the reason we use lead aprons. So photoelectric effect is the one which is responsible for giving a contrast in a X-ray film. CT scan, the principle of CT scan, CT is actually a 3D X-ray. It is 3D because we have a rotating X-ray tube. It is rotating X-ray tube. And each substance, it appears black, it appears white based on its Hounsfield units, the value, the HU value. So remember, Godfrey Hounsfield was the one who invented the first CT machine. Ultrasound is based on the principle of piezoelectric effect. Piezo is like piezo, that is pressure ke saath, it generates electricity. So what happens in ultrasound is, this is the ultrasound probe. We have the electric signal coming in. The crystal here that is of lead zirconium titanate, it has piezoelectric property. So when the electricity comes, it converts this electricity to sound. the sound goes into the patient's body, the sound is reflected back, picked up by this crystal and again converted to electricity. So that is a transducer, converting one form of energy to another. So piezoelectric effect, or it is also called as the pulse echo principle. We send the sound pulse and then we get the echo from the body. So that is the pulse echo principle. MRI is based on the principle of nuclear magnetic resonance or the gyromagnetic property of protons in the body. Remember that it is based on H+, the moving protons in the body. PET, the principle of PET is annihilation coincidence circuit, a previously asked question. So remember this term. So in PET, which is positron emission tomography, not therapy. It's a diagnostic scan. It's not a therapeutic procedure. So we have a positron emitter, which is the positron emitter most commonly used, F18. So this F18 emits the positron, interacts with electron in the body. They both annihilate, that is destroy each other. They generate the two photons in opposite direction. And when they coincide the detector, that is when it is detected. So remember, this is annihilation coincidence is the principle of PET scan. Now, in X-ray, also remember the concept of kVp and MAS. kVp, kilovoltage peak, and milliampere second. So when you increase the kVp, the trick to remember that is kVp, remember, stands for contrast versus penetration. kVp, contrast versus penetration. So increase in kVp increases the penetration, but opposite, it is versus, it decreases the contrast. So that's why in an obese patient, we need to increase the kVp for more penetration, but that will decrease the contrast. On the other hand, when we increase the MAS, that increases the contrast and it causes more blackening in the X-ray film. Now going to the terminologies, the black and white in the various modalities. In a radiograph, something which appears black like air, that is radiolucent. Air is radiolucent. Bones are radio opaque, that is white. So remember in X-ray, jiska density come, that appears more black. Something which is more dense appears white. So example, when there is consolidation in the lung. Consolidation means solidification. So air is replaced by something more dense. That is why consolidation appears white, right? In ultrasound, the terminology used is hypoechoic. Everywhere in radiology, black is hypo and white is hyper. Ultrasound uses sound and sound generates echo. So that is why it is hypoechoic or anechoic. Anechoic means no echo at all. And what appears anechoic on ultrasound is fluid, clear fluid. CT may dark is hyperdense, white is hyperdense because it depends on the density of that material, not the mass density but the electron density of the substance. That decides the HU value of the substance. Higher the HU value, the substance will be white. Lower the HU value, the substance will appear dark. MRI, dark is hypo-intense, white is hyper-intense. Remember in MRI, fat is hyper-intense on both T1 and T2 weighted MRI. Bone, cortex, fibrosis, ligaments, these are hypo-intense on both T1 and T2 weighted MRI. Now coming to X-ray tube construction. Now we said that the X-rays do not come from the nuclear disintegration. So how are the X-rays produced? X-rays are produced when a fast-moving electron beam is suddenly stopped. So the kinetic energy gets converted into heat and X-rays. So this is what happens in the X-ray tube. We have an electron beam ka source, which is the cathode or the filament. When we heat the cathode or filament, it emits the electrons. So basically there is the process of thermionic emission which is happening. It goes towards the anode or the target. That generates the X-rays which comes out through the window. So what is this cathode or filament made up of? It is made up of tungsten plus thorium, TT. What is anode or target made up of? Tungsten plus rhenium. Tungsten ka atomic symbol is W and atomic number is 74. In cathode and anode, amongst that which is rotating in the X-ray tube, it is the anode which is rotating, not the cathode. The rotating anode increases the shelf life of the X-ray tube. The window is made up of glass and we use a filter here after the X-ray tube. Basically, what does it filters out? It filters out the low kV, the low energy X-rays which do not have good penetration. So we don't want unnecessary exposure to the patient, and this filter is made up of low density materials like aluminium and copper and not of lead, right? going to what is the difference between normal X-ray tube and a mammography X-ray tube. Mammography is actually the X-ray of the breast. So it will have radiation exposure, but we do not do mammography in the same machine. The X-ray tube is different. We need a compression plate. So what is the difference in the construction of the mammography X-ray tube? One, the anode here, instead of tungsten, it is made up of molybdenum or rhodium. Rhodium is used in young females who have more dense breast. Rhodium is used as the anode. Window is made up of beryllium and not glass. And filter is also made up of molybdenum and not aluminium or copper. And remember that in mammography, it's a low kV X-ray procedure. Why? When you have low kV, remember KVP, contrast versus penetration. What happens with the low kV? When you decrease the kV, the contrast increases. When the contrast increases, so what happens? It helps in easy identification of microcalcification in the breast, which is what we look for to identify a malignant breast lesion by RADS 5. Right, so remember it's a low kV X-ray. Next one, which are the 5 basic densities of X-ray? So if I tell you that arrange these substances from most black to most white. So most black is air, subset come density. Then you have water, bone and then metal. But remember that fat, this is where majority of the students tend to make a mistake. Fat appears dark on X-ray, less dark than air but more dark than water. Because if I ask, compare the density of fat and water, which is more dense? Water is more dense, fat is less dense. You know that oil and water, oil floats. So that means the fat is less dense, and that is why remember that fat will be darker than water, but it will be brighter than air. It is more dense than air, it will be brighter than air. So something which is more dense appears more bright, something which is less dense appears dark. So remember, these are the 5 basic densities on X-ray that we can identify. Coming to the HU value in CT scan. HU basically stands for Hounsfield units, and it depends on the electron density of the substance. Now, which substance has a HU value of 0? That means it is the reference substance in the CT scan. And that is water. Distilled water has a HU value of 0. So imagine this HU scale is like a numerical scale. You have 0, you have negative and you have positive. So negative means less dense than water and positive means more dense than water. So fat and air will be negative HU value. Bone, soft tissue will be positive HU value. Right? So remember that fat has a negative HU value -50 to -100. Similar to X-ray, it appears dark on CT. So remember that X-ray and CT are basically working on the same principle because both of them are utilizing X-rays. A previously asked FMG exam question. Air has a HU value of -1000. Bone has a HU value of +1000. Okay. Now coming to the ultrasound concept of black and white, the posterior acoustic shadowing and the posterior acoustic enhancement. Shadow we know that appears black. So shadowing will be black. Enhancement in radiology means enhancing, appearing more white. So what gives posterior acoustic shadowing is stones, bones, air. Stones, bones, air give shadowing. Cystic lesion gives enhancement. Why? Because imagine that this is the gallbladder. It has these gallstones within. So when we are doing ultrasound, so the sound is reaching the calculus, the gallstone. It is reflecting back all the sound. So whatever reflects sound appears white. So this calculus by itself is echogenic or hyperechoic. But it is not allowing the sound to pass through it. So behind what happens is there is no sound reaching there. So there is no echo which is produced. So there is no signal. So behind the stone there is no sound reaching. So there is no echo and therefore it appears black. That is posterior, that is behind the stone. Acoustic related to sound, ultrasound and shadowing. So stones, bones and even air, because air is not a good conductor of sound. So it will not allow the sound to penetrate. All of these give posterior acoustic shadowing. But remember that these substances by themselves, they appear hyperechoic on ultrasound. So stones, bones, air, they appear hyperechoic. But behind them, they give a shadow. Now a cystic lesion, that means a fluid containing lesion. When we are doing ultrasound, all the sound passes through the cyst. because fluid is a good conductor of sound. So what happens behind the cyst is a lot of sound reaches there. A lot of sound reaching means a lot of sound reflecting back. So behind the area will appear more white because it is reflecting a lot of sound. So it will be hyperechoic, that is enhancement. So when in an ultrasound I see that there is posterior acoustic enhancement, I know that it's a cystic lesion, and therefore ultrasound is a good investigation to differentiate whether the lesion is a cyst or a solid lesion. So you can see that fluid by itself appears dark, anechoic on ultrasound. Because it is transmitting the sound, it is not reflecting the sound, so it appears dark. And that's why for fluid, ultrasound is a very sensitive investigation. It is appearing dark on ultrasound. Air and calcification will appear white. Fluid will appear black on ultrasound. If it's a pus, fluid having echoes within will be pus or hemorrhage. So basically black with the echoes within, it represents the pus cells or the RBCs. So that helps us to differentiate whether it's a simple cyst or it's a complex cyst, it's a simple pleural effusion or it's a empyema. Right? Now coming to how do you differentiate the various investigations? How do you identify whether this is CT or this is MRI? Now most important here to differentiate is look at the bone, and even in the bone, look at the bone cortex, not at the bone marrow. So in this brain imaging, just outside the brain parenchyma, you see this white skull bone. So that is why this is a CT scan. Here, just outside the brain parenchyma, you see this black line, the black bone cortex. That is the inner table. You have the outer table, and beech mein white is the fat of the diploic space. So the bone cortex is appearing black. So this is MRI. Do not get confused by this white layer outside. This is the fat appearing white on MRI. This is the scalp fat. This is the inner table. This is the outer table. The bone cortex is appearing black. Apply the same concept here and identify which is CT and which is MRI. Now, if you will look at the bone here, the bone marrow appears black, but look at the bone cortex. The cortex is appearing white. So that is why this is a CT scan. Here, this is the cortex of the bone appearing black. So this is MRI. And look at how MRI shows the soft tissues very well. The ligament is seen very well. So MRI is definitely a better investigation for soft tissues. Why is the bone marrow appearing black on CT? Because this is a fat containing, this is a yellow marrow, and fat we know appears dark on CT. The marrow is appearing white here on MRI because again this is fat containing, and we said that on MRI fat is T1 and T2 bright. So always check the bone cortex, the lining of the bone, not the bone marrow, to identify it's CT or it is MRI. Next one, now how do you differentiate whether it's a non-contrast scan or it's a contrast enhanced scan? So CECT, what is the contrast that we use? It is iodinated contrast is what we use. It's iodinated contrast is what we use in CECT. So how do we give this iodinated contrast? It is given IV. Now, how do you identify a contrast scan? The IV contrast goes into the vein, into the heart, and then to the aorta and all the vessels. So basically, it is a vessel which helps us differentiate whether it's a non-contrast CT or it's a contrast enhanced CT. So look at this vessel here. This is the CT scan. First, let me give you an orientation. This is the white bone. So this is CT. This is anterior part. This is posterior part. And this is the left side of the patient. Whatever is your right is the patient's left. Whatever is your left is the patient's right. Why? Because imagine that this is the patient lying supine and you are looking at the patient from the foot end. So a patient lying supine, you are looking at the patient from the foot end in CT scan. So what happens is whatever is your right is actually the patient's left. Whatever is above in the image, that is the anterior aspect. Whatever is below the spine, that is the posterior aspect. So this structure that you are seeing here, this is the circular structure here is the aorta to the left of the vertebra. Aorta is grey color similar to the other like the muscles here. It's a non-contrast CT. Look at the aorta here, compare with the soft tissue. It is more white. It's a contrast enhanced CT. That is how we differentiate non-contrast from contrast. And what is the test that should be done before giving this IV iodinated contrast? It is KFT or RFT, And the easiest is the serum creatinine is what needs to be done, because this can have nephrotoxicity and this contrast is excreted by the kidneys. So the renal function should be good before we give this IV contrast. And why do we need to do contrast scan? Is look at the difference between two images. This is the same patient, non-contrast CT, contrast CT. This is the liver on the right and the spleen on the left. Non-contrast CT, you don't see the lesions which you are seeing in the contrast scan. Why? Because in non-contrast CT, the lesions are having the same density like the adjacent liver. Remember, we'll see the silhouette sign in respiratory radiology. Same density saath mein aa gaye. So they look similar and we cannot differentiate. When we give contrast, the lesion shows enhancement different from the adjacent liver, and that is why we can pick it up. So any space occupying lesion, we do a contrast scan. Infective pathology, inflammatory pathology, we do a contrast scan. So now we are going to learn about MRI sequences. Now if you look at these images, all of them have the black bone cortex. So this is MRI. Now the crux of identifying these basic MRI sequences T1, T2 and flare is when the water is white. The MRI sequence that we have is with white water. Remember, water white is World War II. WW2, white water is 2. That means it is a T2 weighted MRI. When the white matter is white, that means anatomy is being followed. White is white, gray is gray. So in that case, it's a T1 weighted MRI because 1 stands for anatomy, the first year MBBS subject. That is followed here, white is white and gray is gray. Then we have the MRI sequence where everything is black. That means water is also black. The white matter is also black. All black is a flare sequence, that is fluid attenuation inversion recovery sequence. So here the fluid gets attenuated, that is CSF gets suppressed, CSF becomes dark, and that is what we see in arachnoid cyst, which contains a CSF. It gets suppressed on flare, while epidermoid cyst does not get suppressed on flare. Now let's have a look at the identification. Now which of these images is a T2 weighted MRI? The one where you see the water is white. So this one, the ventricle water, the sulcal space CSF white, this becomes a T2 weighted MRI. Which of these is T1 weighted MRI? So where you see the white matter is white, the corpus callosum, the internal capsule is white, that is a T1 weighted MRI. Here it is all black. The water and the white matter both is black. So this becomes a flare sequence. Now a sequence which looks similar to flare, that is all black, but it does not have the surrounding scalp, the fat there, the skull bone there. That's a diffusion weighted imaging. And complementary to that we get the ADC map, apparent diffusion coefficient. So a pathology which shows the signal opposite to CSF, CSF black, pathology white, CSF white, pathology black, that is called as restricted diffusion. So restricted diffusion means opposite of CSF because CSF is facilitated diffusion. So remember, acute infarct gives restricted diffusion, high grade tumors, hypercellular tumors, epidermoid cyst and abscess, these are some of the conditions that give restricted diffusion. The next sequence is SWI, that is susceptibility weighted imaging, which is the most sensitive sequence for hemorrhage. It is also a sequence which helps us differentiate hemorrhage, that is hemosiderin versus calcification. So which trauma condition is this the investigation of choice? This is the investigation of choice for diffuse axonal injury, where we want to see for punctate hemorrhages, the petechial hemorrhages. We can also use T2 star GRE sequence for hemorrhage. These hemorrhages appear as black areas. Like you see here, these are called as areas of blooming. But SWI, remember, is more sensitive than T2 star GRE sequence. Now, the advanced sequences here, we have DTI, that is diffusion tensor imaging, which is based on anisotropy of the white matter tracks. So here you see that tensor imaging is like tractography. So you have the colorful white matter tracks here. In the MRI sequence where the white matter tracks appear colorful, that is a tractography. Next one, bold MRI, that is blood oxygen level dependent MRI, which is also called as functional MRI, which helps us evaluate and localize the functional, the eloquent areas of the brain, like the visual cortex, the speech motor cortex, Broca's area, all of that. That is the bold MRI. So here what happens is we activate the functional area by giving the stimulus, and that area gets lighted up and we can localize that area. This helps in neurosurgery planning, helping us to avoid the damage to the eloquent areas. Next is MR spectroscopy. As the term says, spectro, matlab it gives a spectrum, a graph. So you can see it gives a graph like this. This graph represents the chemical constituents of a lesion. And based on that, we can narrow down the differential to a diagnosis. Like if there is choline peak, then it is most likely to be a primary brain tumor. Normal brain parenchyma has NAAP. Pathologies which destroy the brain and neurons, so they will cause a decrease in the NAA peak. TB on the other hand gives a lipid peak because TB bacterium has mycolipid, so it gives the lipid peak. Now coming to ultrasound ka basics, a quick overview of that. So if ever you've undergone an ultrasound, you would see that there are multiple probes in the ultrasound machine. We have the convex probe, we have the linear probe. So this is the probe, the small footprint wala is for the echocardiography. So why do we need these multiple probes in ultrasound? Is because they emit the sound frequencies or which are different. So what is the advantage? So this linear probe, for example, is a high frequency probe. What is the frequency of sound used in sonography? It is ultrasound. Ultra means higher level than what we can hear. It is in megahertz. It is not even in kilohertz. 2 to 15 megahertz. So higher the frequency that is emitted, the penetration is less, but the resolution is better. That is the advantage. So these linear probes, these are used for superficial structures where we don't need a lot of penetration, like ultrasound thyroid, ultrasound breast, ultrasound scrotum. That is where we use them. Convex probes are used in ultrasound abdomen, obstetric ultrasound, where we need deeper penetration. This probe, the long probe, this is the intracavitary probe which is used for transvaginal sonography or transrectal ultrasound. Now, what are the various modes of ultrasound? First is the A mode. A for amplitude, it just shows the amplitude here. And we use this A mode is basically the A scan, which you must have read in ophthalmology. A for measuring the axial length of the eyeball. This is used for measuring the axial length of the eyeball when we want to calculate the power of the IOL. B mode stands for B for brightness. You can remember B for black and white. So the routine black and white ultrasound that we see, the grayscale ultrasound, that is the B mode of ultrasound. In the eye, the B mode, the B scan is used for the posterior segment of the eye. It helps us evaluate vitreous hemorrhage, retinal detachment. M mode, M for motion, M for movement. So this is used to evaluate the movement in a structure, right? So for example, fetal heart rate जब calculate करना होता है, obstetric ultrasound, we use the M mode of ultrasound. It shows the movement of the structure. Next is the Doppler mode of ultrasound. Doppler basically is for the blood flow and it is based on the change in the frequency of the sound. The Doppler effect is based in the change in the frequency of the sound. So if there is a color present on the Doppler, that tells you that there is a flow present in the blood vessel. Thrombus in the blood vessel will not show the color, right? But remember, the Doppler should never be done at an angle of 90 degree because it will give a falsely absent blood flow, a false thrombus, right? The angle should be less than 60 degree when we are doing Doppler. So Doppler, basically in ultrasound, if you see this red and blue color, that is the color Doppler. Along with that, if you see a graph like this, which has been asked in one of the recent exam, that is a spectral Doppler. Graph again means spectrum. So that is a spectral Doppler or a duplex Doppler. And what does the color indicate in the color Doppler, the red color, the blue color? It indicates the direction of the blood flow. You can remember it with the mnemonic that is red tower blows away. Okay, imagine the WTC attack. It was a red tower which was blown away. So remember that red tower, red is towards the transducer, is blue is away from the transducer. Okay. Now, what is this investigation here? When you see an ultrasound image which is orange color, it is a contrast enhanced ultrasound. What is the contrast used? It is microbubbles of sulfur hexafluoride gas which is given IV. And it is excreted by the lungs, therefore it is safe in renal failure. Contrast enhanced ultrasound is commonly used in liver lesion characterization, and now it has many other applications as well. Next, what is this ultrasound here? This is elastography. So when you see in the ultrasound, this colorful image, not just the orange color, but you see the red, green, blue color, and side may you see a scale which is mentioning kPa, that is kilopascals. So that is basically we are giving the pressure with the probe and we are checking for the strain of the lesion, the elasticity of the lesion. So elastography helps us in evaluating how soft or how hard a lesion is. Same thing can be applied to liver also. It can help us to evaluate the cirrhotic changes in a fatty liver, right? That is where we do this fibroscan. So remember, this is elastography. A malignant lesion will be more hard. A benign lesion will be more soft. So that is how it helps us evaluate benign versus malignant. Now coming to the very, very important concept here, the investigation of choice. What are the general principles in answering the questions when you are asked what will be the investigation of choice in a particular condition? So when it's an air containing pathology, so remember that for air, ultrasound is not good because air is a bad conductor. In MRI, air does not give a signal. So for air, it is CT scan. So pneumothorax, pneumoperitoneum, the most sensitive investigation would be CT. Okay, so for the pneumo containing, it's going to be CT. For fluid, remember fluid is it is ultrasound. How does fluid appear on ultrasound? We have already seen it appears black and echoic. For calcification, again C for C, remember it is CT. It appears white on CT. Calcification appears white on CT. For soft tissues, definitely it is MRI because MRI has a higher soft tissue resolution. What is included in the soft tissues? The muscles, ligaments, tendons, neurovascular structures, all of these are better seen on MRI. So when you have a patient with ACL tear, you have a patient with meniscal tear, for all of these, we would be doing MRI. For bone, cortex and bone marrow, cortex, C for C, CT scan. For bone marrow, it is going to be MRI. For medical device positioning like pacemaker ke leads, a central venous line, is it properly positioned? Endotracheal tube, is it properly positioned? X-ray is a good investigation to localize them. For vascular pathologies, the first investigation, if it's an accessible vessel, it's a Doppler, or generally the investigation of choice is CT angio. The gold standard generally is DSA. But remember that for aneurysm, better than DSA is CT angio, because if you want to do the surgery, you want to put the implant for the aneurysm, in that case, the graft ka size has to be based on the aneurysm ka size, the vessel ka size. In DSA will only evaluate the patent lumen of the vessel, not the thrombus in the vessel. While in CT scan, even the thrombus will be evaluated and we will get the true size of the vessel and not just the patent lumen. So remember that before surgery, the investigation that we need to do for aneurysm is CT angio. So look at these some images here. What is this image showing? This is a metallic foreign body. How do I know that? Because it's white and it is giving this artifact, the streak artifact. So remember, for metallic foreign bodies, MRI is contraindicated. Any metal is contraindicated in MRI. So for those, what is the investigation of choice? First is X-ray, better than that is CT scan. Next one, what are we seeing here? On CT scan, this is a hyperdense pathology, white but not as white as a bone. So this is acute hemorrhage. Acute hemorrhage, calcification appear white on non-contrast CT. So for acute hemorrhage, it is non-contrast CT. For chronic hemorrhage, the investigation of choice is MRI because it helps us pick up the hemosiderin in the chronic hemorrhage. The iron component there helps us pick up the hemosiderin component. Next, what is this lesion containing? So a renal lesion appearing dirty black with some vascular components there. This is dirty black is fat containing. So the renal lesion containing fat is angiomyolipoma. Lipoma is the fat containing lesion, right? So remember that for fat containing, how do we identify the fat? On CT scan, it has a negative HU value. We have already seen that. On ultrasound, fat appears hyperechoic. On MRI, it appears hyperintense on both T1 and T2 weighted MRI. If you do a fat suppressed sequence in MRI, this will become dark. Fat will become dark on fat suppressed sequences. Next one, what is this? This is jet black. That means this is air containing pathology outside the lung. This is pneumothorax. So remember, for that, CT scan is the most sensitive investigation. Pneumothorax also is evaluated in E-FAST, extended FAST, which is extended to include thoracic cavity. What do we see is the barcode sign, the stratosphere sign, the lung point sign. We have seen that in respiratory radiology. Now, coming to where are the various types of CTs, the investigation of choice. So, non-contrast CT, something which appears white on non-contrast CT will be evaluated on non-contrast CT. So, acute hemorrhage, because it is dense, so it appears hyperdense because of the fresh RBCs. Calcification, again it is dense, so it appears white. So, for acute hemorrhage calcification, it is non-contrast CT. Contrast scans we have seen is done for space occupying lesion, infections and inflammatory disorders. HRCT is the investigation of choice where you have air surrounded by bone. So, the lung pathologies, lung containing air surrounded by thoracic cavity. So, we have for interstitial lung disease and bronchiectasis. HRCT is the investigation of choice. Also for paranasal sinuses containing air surrounded by bone, and also for the temporal bone, middle ear containing air surrounded by bone, mastoid air cells, it is HRCT. But remember that if in a temporal bone fracture, you are suspecting facial nerve injury. So when it's a nerve injury, we will have to do MRI in that case. Next one, dual energy CT is done for uric acid identification. Triple phase CT is done for liver lesion. It helps us identify the lesions based on the enhancement covered in hepatobiliary radiology. CT enterography is a good investigation for small bowel mucosal lesions, like to look for the activity of Crohn's disease, to look for polyps. CT enterography is a good investigation. It is done giving oral mannitol. CT cisternography. So from the cistern, so basically we put contrast in the cisterns. How? By doing like lumbar puncture wala procedure. We put the contrast there. We give the prone position. We look for the CSF leak. So this is basically done for CSF leak. CT perfusion helps us in evaluation of penumbra in a patient of stroke, acute infarct. How much is the salvageable area? And CT urography is for the renal pathologies. Now IVP has been replaced by CT IVU. So CT IVU is for the renal pathologies like the stones, like TB. CT guided RFA, radio frequency ablation. This is the therapeutic application of CT, and this is used for treatment of which bone tumor? Osteoid osteoma, where we ablate the central nidus. This is also used in treatment of liver metastasis, right? And CT guided biopsy is basically a diagnostic procedure where under the CT guidance we can do the biopsy, commonly done for lung pathologies, the solitary pulmonary nodule, and we can do for bone biopsy as well, the vertebral lesions. So these are the various applications of CT. Now going to the various applications of USD. A mode, we said A scan is for the axial length of the eyeball. B mode is the routine black and white ultrasound in the eye. This is for the posterior segment of the eye. Doppler is for the vascular pathologies. Vascular pathologies like peripheral vascular disease, we are suspecting arterial stenosis. For varicose veins, DVT, portal hypertension, we can identify by Doppler. Renal artery stenosis, that's the initial investigation. So basically for vascular pathologies like carotid stenosis, carotid atherosclerosis, we do Doppler. M mode is for the motion. So for fetal heart rate calculation, we said for pneumothorax, we do the M mode. We can also look for diaphragmatic palsy, right? We can look for the movement of the diaphragm. Contrast enhanced ultrasound, the liver lesion, we said commonly used there. Elastography helps us in differentiating malignant from a benign lesion, especially in the breast, thyroid lesions. This is commonly used. Fatty liver, to identify how much cirrhosis, fibrotic changes it is undergoing, we use elastography. Tissue harmonic imaging. Remember, harmonics is related to the sound waves. So this is a type of ultrasound which helps in better penetration. So especially in obese people, this gives a better resolution image. Tissue harmonic imaging. HIFO is high intensity focused ultrasound. So a high intensity ultrasound beam is focused on the lesion and it ablates the lesion. So this is the therapeutic application of ultrasound. This is used commonly for uterine fibroid treatment. Next we have the various MRI sequences and their applications. FLAIR is the most sensitive sequence basically to identify brain pathologies and edema. Because in FLAIR we said that it is all black. So the pathology looks white and it stands out in all black background. Similar to FLAIR, for the musculoskeletal MRI, we have a STIR sequence which is basically a fat suppressed sequence. So what does it do? It makes the fat black. So the marrow fat becomes black. So whatever is white on STIR is abnormal. So this is a good sequence to pick up the bone marrow edema in various pathologies like osteomyelitis, ankylosing spondylitis, all of those. SWI is for hemorrhage and to differentiate hemorrhage iron versus calcification. Contrast enhanced MRI, any space occupying lesion, especially in the brain, MRI is the investigation of choice. Spinal cord, MRI is the investigation of choice. MR venogram is for the dural venous sinus thrombosis. MR angio is to look for arteries, arterial pathologies like in a patient of stroke or any stenosis, aneurysm we want to see, we will do MR angio. And MRCP is cholangiopancreaticography. So to look for the bile duct pathologies and the pancreatic duct pathologies, like we want to look for dilated pancreatic duct in chronic pancreatitis, we will do MRCP, right? So these are the various applications. Now going to region wise, what is the investigation of choice? So for brain pathologies, MRI is preferred over CT because it gives a better resolution, helps us differentiate gray matter, white matter very well. But CT is generally the first investigation that we do. Non-contrast CT is the investigation of choice for head trauma because acute hemorrhage fractures can be identified, except for diffuse axonal injury where MRI is the investigation of choice. Rest everywhere, generally it is MRI. For chest, that is the lungs, the air containing organs, it is CT scan which is the investigation of choice. First is chest x-ray, then we do CT scan. For mediastinal mass, anterior mediastinal mass, it is contrast enhanced CT. Posterior mediastinal mass, it is MRI because the most common posterior mediastinal mass is neurogenic tumors, neurogenic nerves, soft tissue, MRI is better. In the lungs, we do CT angio for which pathology? Pulmonary sequestration, we do CT angio. Why? Because sequestration basically means a part of the lung which is not supplied by pulmonary artery but by aorta or its branch, that is systemic circulation. So we need to identify the blood supply there, so we do angio, CT angio there. For upper abdomen, especially gallbladder, it is ultrasound because it's a superficial organ, it's a fluid containing organ, so ultrasound. For pancreas, CT scan is better than ultrasound because it does not limit the visualization of pancreas. Pelvis के लिए generally it is ultrasound. For pelvic pathologies, the first is ultrasound. Better than ultrasound is MRI. So for pelvic malignancies evaluation like CS cervix, we have MRI which is done. For perineal pathologies, again it is MRI like fistula in anorectal malformations, we do MRI. For bones, cortex is CT. For bone marrow, it is MRI. So example of cortical pathology in bones, which tumor? Osteoid osteoma. So remember in bone tumors, MRI is better, but except in osteoid osteoma where we want to look for that cortical thickening and the nidus, CT scan is better. For rest like osteomyelitis, bone tumors, ankylosing spondylitis, MRI is the most sensitive. For soft tissues, again it is MRI. For foreign body, first is X-ray, better than that is CT. Do not do MRI in metallic foreign body. For blood vessels, we said it is Doppler, CT angio, MR angio and DSA. So let's have a look at the investigation for various vascular pathologies, that is the various angiographies here. So what do we see here? First one is the Doppler. Ultrasound mein for blood vessel it is Doppler. The color indicates the presence of flow, that is what we already said. This is a CT angio where we see the white bone and we see the white vessels. The rest of the brain parenchyma is suppressed. This is CT angio. This is MR angio, where we don't see the white bones, right? No white bones means it is not CT. And this one, where you see the vessel is black, then it's a DSA, that is digital subtraction angiography. So remember that whenever you have a black vessel, it's always a DSA. Now that does not mean that in DSA always the vessel will be black. It can be black or it can be white, because this is the procedure which is done under fluoroscopy, right? So it can appear black. Out of these, DSA is the one which is invasive, because we actually put the catheter into the artery. So the contrast given is intra-arterial. So that is why we reserve it for the last. So it is the gold standard investigation. Advantage with DSA is it can be therapeutic also, because we are going into the artery. CT angio is generally the investigation of choice for vascular pathologies like aneurysm, dissection, because it is quick, easily available. And advantage with MRI is MR angio is the one which can be done even without contrast. The sequence that we use there is TOF, that is time of flight sequence is used there. So these are the pros and cons of all the various angiographies. Now coming to identifying the various machines and the equipments, even that can come as an image based question. So the first one that you see here is a cassette in which we put the X-ray film. So the first question here, what is the X-ray film? The active emulsion made up of? It is made up of silver halide. Which is the maximum silver halide there? It is silver bromide. An advance over conventional radiography is this CR, that is computed radiography. What do you see here is, we are putting this plate-like thing into a scanner. So this is the PSP plate, the photo stimulable phosphor plate, which can be reused unlike the film in conventional radiography. It gives the image on the computer. It's a computed radiography. This one is a digital radiography, where as soon as the X-ray tube sending the X-rays, the image is reconstructed and you directly get the image on the computer. So this is the fastest mode of getting the X-ray image. And this is also the advantage of this is PACS compatible. That means the digital images can be shared across. What is the full form of PACS? It is picture, archiving and communication system. Okay, this picture, archiving and communication system. So we save the image, we communicate with others, that is PACS. Now differentiating CT from MRI. Now if you have seen or undergone MRI any time, many patients have claustrophobia there, because MRI is a closed tunnel, right? So that leads to claustrophobia. So when you see a closed tunnel-like thing, then it is MRI. When it is just one single round thing like this, you can see the back wall there, then it is CT scan. So this is CT, and where you have tunnel, you can also see the use of the coils here. RF coils are used around the area of interest that we are imaging. That is MRI. And this one, of course, is ultrasound, where you can see this ultrasound probes. So remember, ultrasound and MRI do not have radiation exposure. We have already seen that. The next images that we have here, what is this one? This is barium swallow being undertaken here. So whenever we have an investigation for a moving structure, we can do fluoroscopy. So all the GI studies, the barium studies are done under fluoroscopy. They help us see the peristalsis, the movement of the bolus, right? So this is fluoroscopy, which is basically a video X-ray. So definitely it has radiation exposure. Now fluoroscopy is also used in C-arm, which is commonly used in ortho-OT, right? So this is also the fluoroscopy. Next, you can see the C-arm here, that is the fluoroscopy system, which is also used in DSA, digital subtraction imaging, that we were talking about, which subtracts the bones and it gives the image only of the vessels. So this DSA, remember, is done under fluoroscopy intra-arterial contrast. This image here, this is mammography machine. How do I know that? Is by this compression plate. So in mammography, compression is a must, and it also has radiation exposure because it's a X-ray. This one, something which is coming overhead like this This is a DEXA machine, dual energy X-ray absorptiometer, which helps in evaluating the bone mineral density and thereby helps us diagnose osteoporosis. This is DEXA. What is this investigation being done here? So you can see something in the patient's mouth, which is put like an occluder, and then the X-ray tube rotates and takes the entire panoramic image of the dentition. So this is called as OPG, that is orthopentomogram, which is done for the dentition, like dental caries. It is done for the dentigerous cyst, TM joint abnormalities, all of those. Now, what is this machine here? So you see something like electrode coming into the patient's body. There are those electrodes which are put into the patient's body. The electrode goes into the lesion, like here it is going into the liver lesion, opening like a flower, and then it ablates the lesion by radio frequency. So this is used in treatment of which bone tumor? Osteoid osteoma, also used in liver metastasis. Now, going to contrast media. Why do we need contrast? As the term says, to give a contrast to a lesion and to make a lesion look better. So we have positive contrast, negative contrast. Positive means white appearing, negative means black, like we have air which is black. So what are the various contrast media that we have here? One is iodinated contrast. Then we have gadolinium, we have sonoview, we have barium. These are used in various investigations. Like where do we use these iodinated contrast? Look at the image carefully. It is mentioned it is Omnipac iohexol. So it tells you that it's a iodinated contrast. So iodinated contrast is used in any investigation which is based on X-rays. So contrast X-rays, that is the dye studies like IVP, HSD, MCU, all of those they use iodinated contrast. Then we have CT scan, contrast enhanced CT, because CT is also X-ray based. So there also we use iodinated contrast. Gadolinium is the contrast used in MRI. Why? Because gadolinium is a paramagnetic substance and MRI is all based on magnetic properties. So gadolinium, what does it do is it makes the things look brighter on T1. So gadolinium, the contrast enhanced MRI is generally T1 weighted MRI. Sonoview is, you can see the brand name here, Sonoview. The term itself tells you that this is a sonography contrast. So contrast enhanced ultrasound, we saw that these are micro bubbles of sulfur hexafluoride gas which are put in a phospholipid shell. They are given IV, but the advantage here is they are excreted by the lungs, so they are safe in renal failure. Iodinated gadolinium, these are excreted by the kidney, and that is why we need to have a normal renal function before we give this contrast, but Sonoview is safe even in renal failure. Next is barium. Now barium is used only for the GIT pathologies, not intravascular, because it is water insoluble. So what compound of barium is used as a contrast? It is barium sulfate. It is barium sulfate which is used. We can give oral, we can give rectal barium. Remember, this is contraindicated in perforation, be it esophageal, intestinal perforation, small bowel obstruction. In those cases, this is contraindicated because if it goes out into the peritoneum, it will irritate the peritoneum and cause peritonitis because it does not get absorbed. So that's why in cases of perforation, what do we use is the water soluble iodinated contrast. What is preferred? The low osmolar non-ionic contrast iohexol is preferred over gastrographin, which is basically a brand name of iodinated contrast. Now coming to some classification of iodinated contrast media, because this can be asked in the exam, the iodine particle ratio, low osmolality, ionic, non-ionic. So the classification of iodinated contrast media, they can be ionic, they can be non-ionic, they can be monomer, they can be dimer. So we have 4 classes: ionic monomer, ionic dimer, non-ionic monomer, non-ionic dimer. Now, how do we identify whether this contrast is ionic or non-ionic? Look at the spelling. If it ends in ATE, it is ionic, like carboxylate, ditrizoate, right? So, ditrizoate, metrizoate, ioxaglate, the acids, the iothalamate, these are ionic contrast. The non-ATE, the OL ending, these are going to be non-ionic. So, iohexol, iopamidol, ioversol, iodixanol, all of these are non-ionic. Now, how do you remember which is a monomer and which is a dimer? So, for that, what you can do is remember the dimer ka example in ionic and non-ionic, because we have 1-1 contrast there. So, remember ioxaglate is an ionic dimer. The rest of them are ionic monomer. Iodixanol is a non-ionic dimer. The rest of them are monomer. How do we remember the example? So when I write iodixanol, so remember the di tells me that it's a dimer. The OL tells me that it is non-ionic dimer. And remember, this is the one which is iso-osmolar contrast. Its brand name is Visipac. Okay, this is iso-osmolar. So that means this is the safest for the kidney. Okay, which is the ionic monomer? So remember, ioxaglate. Glate, GL is like glue and glue is like 2, that is dimer. So remember, ioxaglate is ionic dimer. The rest of them are monomer. So ditrizoate wala brand name hota hai gastrographin, urographin. Now coming to the iodine particle ratio. The number of iodine is decided by whether the contrast is a monomer or a dimer. If it's a monomer, it gives 3 iodine. If it's a dimer, double, it gives 6 iodine. The number of particles is decided whether it's ionic or non-ionic. If it is ionic, it ionizes, positive, negative, it gives 2 particles. If it is non-ionic, it is not ionizing, staying as one complete particle, so it gives 1 particle. So if I ask you the iodine particle ratio of ionic monomer, we are asking iodine particle ratio. So number of iodine, monomer hai to 3 iodine, ionic hai to 2 particles, so this will be 3:2. Ionic dimer will give 6 iodine, ionic will give 2 particles, 6:2, that is 3:1. Non-ionic monomer 3 iodine, non-ionic 1 particle, 3:1. Non-ionic dimer will give 6 iodine, non-ionic will give 1 particle, 6:1. So easy to identify the iodine particle ratio. Now there are 2 groups which have the iodine particle ratio of 3:1, and these are the ones which are low osmolar. So remember, ionic dimer, non-ionic monomer are low osmolar. Most commonly used in practice is iohexol, which is a non-ionic monomer, a low osmolar contrast. Ionic monomer, which gives 2 particles. Effectively, you see that this is the group which is giving 2 particles, the rest are giving 1 particles. So this is the one giving 2 particles which has high osmolality. So these are the high osmolar contrast medium, that is ionic monomer, and we do not prefer them using now, right? So that is about the classification of iodinated contrast media. Now coming to radiation units. What is the conventional unit? What is the SI unit for radiation exposure, absorbed dose, equivalent dose and effective dose? So remember that the first thing that happens is the radiation exposure. So first we are exposed to radiation, then we absorb the radiation, then depending on the type of radiation we have the damage in the body. Depending on the tissue sensitivity we have the damage in the body. So exposure conventional unit is Röntgen. Remember, first is exposure and the first person who discovered X-rays is Röntgen. So R, all the conventional units, remember they are starting with R. Röntgen, rad, rem. Okay. SI unit for exposure is basically like ionization. So creating a positive and a negative charge, and for charge the SI unit is coulomb. So remember that it is coulomb per kg, which is the SI unit. Next is the absorption. Now absorption is basically the energy deposited per unit weight. So the SI unit is like joules per kg, which is also called as Gray. How do we remember these are? For radiation absorbed dose, remember RAD, that is the first alphabet. So RAD is the conventional unit, rad is the conventional unit for absorbed dose. R starting with R, that is going to be conventional. Rad is one color, red is one color, along with that goes gray. So red R is conventional, gray non-R is the SI unit. For equivalent dose, effective dose, the EE wale. Equivalent dose depends on the type of radiation. Effective dose depends on the tissue sensitivity to radiation. For both of them, conventional unit again starting with R, EE equivalent effective. So REM is the conventional unit for these. C word, when I write C word, SI unit for E, that is equivalent and effective dose is C word. Now 1 gray is equal to how many rads? 100 rads. 1 C word is equal to how many REM? It is 100 REM. So these are the various radiation units. Also remember for radioactivity, the conventional unit and the SI unit. Conventional unit C for C, conventional unit is Curie, SI unit is Becquerel, which is also called as disintegration per second. So radioactivity is how much nuclear disintegration is happening per second. So 1 curie is equal to 3.7 into 10 raised to power 10 becquerel. That is 37 gigabecquerel. So these are the various radiation units. So how much radiation do we get in a particular investigation? So how much do we get in one chest X-ray? So look at this, one single PA view of the chest X-ray is 0.02 millisieverts, and CT chest is 8 millisieverts, which is approximately equal to 400 chest X-rays. So for the CT scan, going from above down, head, chest, abdomen. So remember, it is 2, 8, 10. Okay, so it is 2 millisieverts, 8 millisieverts and 10 millisieverts. Abdomen has the maximum radiation exposure. Mammography as compared to chest X-ray has more radiation exposure, which is around 0.4 to 0.5 millisieverts, which is approximately equal to 20 to 25 chest X-rays. All the nuclear scans, the PET scan, the scintigraphies, all of those also have radiation exposure, right? So, what are the various radiation hazards that are there? Now, we know that these ionizing radiation are damaging, right? So, we have deterministic hazards and stochastic hazards. What do we mean by them? Deterministic means we can determine the threshold. Below that threshold, that hazard will not occur. Example, skin erythema. Example, cataract, bone marrow suppression. All of these are deterministic. They have a threshold. They do not occur below that threshold. But once the threshold is reached, as the dose increases, the severity of those occurring increases. So remember that they have a threshold and the severity is dose dependent. Now, stochastic effects. Stochastic effects, remember CHA, basically they occur by chance. That means they can occur at any dose. Low dose also, high dose also, we don't know they will occur at what dose. That means they do not have a threshold. But of course, with increasing dose, the probability of occurrence increases. It's not the severity, it's the probability. Example is radiation-induced cancer, mutations, chromosomal abnormalities, congenital malformations. These are like all or none phenomenon and they can occur at any dose. So stochastic is by chance and the severity is independent of the dose. It is the probability which is dependent on the dose, right? So there is no threshold for them. So look at this. This is deterministic effect. Below the threshold, it does not occur. As the dose increases, the severity increases. Stochastic can occur even at low dose, high dose, and with increasing dose, it is the probability of effect, not the severity of effect, which goes on increasing. Which is the most common radiation-induced cancer? It is leukemia. Which is the thyroid cancer which is radiation-induced? It is papillary carcinoma, right? Now, there is something called as acute radiation syndrome, which occurs when there is a high radiation exposure in short time. So, the first symptom that we have there, the prodromal phase, this has nausea, vomiting. Acute radiation syndrome occurs when the dose exceeds more than 1 gray, right? That means 100 rads. Okay, that is 100 rads. Now, after this NVD phase, nausea, vomiting, diarrhea, then we have the incubation phase, which comes as asymptomatic, and then comes the onset of the various syndromes. First is the hematopoietic syndrome, the bone marrow suppression, then the GIT, and then the last to be affected is the CNS. So, these occur at doses of 3 gray or more is the bone marrow, then around 8 gray, 6 to 8 grays is the GIT, more than 10 to 25 is the CNS. So remember that first to occur is the bone marrow suppression and all these occur at more than 1 gray, right? More than 1 gray exposure in a short time. So what are the AERB guidelines for personal protection? So we have seen that radiation can be damaging. It has its hazards. So there have to be some regulations. Ki general public mein, this is the radiation exposure that is allowed. In occupational workers, this is the radiation exposure that is allowed. And we use protective measures to protect from the radiation. So according to the AERB, which is Atomic Energy Regulatory Board, which regulates in India, what is the minimum thickness of the lead apron? The minimum thickness according to the Indian guidelines is 0.25 mm. According to the international guidelines, it is 0.5 mm. But the most common which is used even in India is 0.5 mm. So Indians are happy even with the lower thickness, right? We know how to compromise and adjust. But for Indians, even for Indians, the gonads are important. We will not compromise in gonadal shield. If the question is according to AERB, what is the minimum gonadal shield thickness? Then it is 0.5 mm is for gonadal shield, 0.25 mm is for aprons and gloves. The protective barrier which is there in the X-ray room, that should have the minimum thickness of 1.5 mm. Now, what are the dose limits which are set? Now, the dose limitations for general public for whole body is 1 millisievert per year. And that for the occupational workers, maximum in any single year is 30 millisieverts. Over a period of 5 years, it is not 150 millisieverts, it is 100 millisieverts. Over 5 years, that is 20 millisieverts per year when you average it over a period of 5 years. But in any particular year, the maximum is 30 millisieverts. For lens of the eye, it is 150 millisieverts for occupational workers. For public, it is 1/10 15. For skin, it is 550, again 1/10. How do we remember these values are? So remember that when I write lens, L is like number 1, E is the 5th alphabet, so it is 15 and 150. Skin, when I write S, it is like number 5, so it is 50 50 wala. Okay? So 15, 150, 50, 500. For extremities, again extremities, the 5th alphabet, it is 500 for extremities also. So skin and extremities, it is 500. For pregnant radiation workers, after declaration of pregnancy, how much dose to the embryo? Maximum is 1 millisievert for the embryo. If the question is कि pregnant female को कितना dose चलता है, then it is 2 millisieverts. For embryo 1, for pregnant female, count like the female and the embryo 1 plus 1, it is 2. According to the NCRP guidelines, that is international guidelines, in pregnancy it is 5 millisieverts and it is also equal to 0.5 rads in the entire pregnancy, right? So if you do not have 2 millisieverts in the option, then go with the option of 5 millisieverts if it is based on international guidelines. So how do we monitor ki in the occupational worker, how much dose are they getting over a period of time? So we need to do regular monitoring, measure the dose. So this is done most commonly by using this TLD batch. TLD stands for thermoluminescent dosimeter. Okay, this is thermoluminescent dosimeter, which measures the dose that a person has received during a particular period of time. How frequently is this monitored? You can see in the image itself here, it's written October to December. So October, November, December, valid for 3 months. So this is monitored every 3 months. That means a quarter of the year. And what is it made up of? Calcium sulfate dysprosium. This TLD has a disc which contains calcium sulfate dysprosium, which holds the radiation as a latent dose, and then it shows thermoluminescence when we heat it and it emits the light and we can measure the radiation. So this is TLD batch. Should we wear it above the lead apron, below the lead apron? It should be worn below the lead apron because we don't want false high values if we wear it over the lead apron. Lead apron is protecting us from some radiation, so the true radiation is below the lead apron. Right? So hello friends, now we are going to learn about musculoskeletal radiology in a rapid review. So for the various modalities that we have here, the first investigation which we do is X-ray. CT scan is done for bone cortex, C for CT, for fractures, and for which bone tumor? Osteoid osteoma, because it's a cortical based tumor, it has cortical thickening with a nidus. MRI is for bone marrow, M for M, MRI is for bone marrow. So bone marrow edema like in stress fracture, avascular necrosis, ankylosing spondylitis, osteomyelitis, MRI is the most sensitive investigation. Even for evaluation of bone tumors to look for the extra osseous extension, how much they've gone into the soft tissues, the neurovascular bundle involvement, all of that is seen on MRI. Next, let's have a look at the normal anatomy in most important musculoskeletal radiographs which are frequently asked in the exam. So what do we see here? Which is the coracoid process, which is the acromion process. So remember the simple concept that coracoid is infraclavicular. So what you see infraclavicular, that is going to be coracoid process. Clavicle goes and articulates with the acromion process to form the acromioclavicular joint. So this is going to be the acromion process with which the clavicle is articulating. So this is coracoid and this is the acromion process. In X-ray pelvis, this foramen that you see here is the obturator foramen that we are seeing here. Then what do we see is this is the lesser trochanter and here we have the greater trochanter, and this is the sacroiliac joint, which is the first to be involved in ankylosing spondylitis, and this is pubic symphysis, which is a type of secondary cartilaginous joint asked many times in the FMGE exam. On greater trochanter, remember the muscles that are inserted. We have gluteus medius, gluteus minimus and not gluteus maximus. On lesser trochanter, we have iliopsoas, which is inserted. This is the X-ray elbow. How do we identify medial and lateral epicondyle based on where is radius and where is ulna? So radius is the one which ends here, and ulna is the one which goes above. The olecranon process goes there. So the one bone going above is the ulna. This is the radius. Radius is the lateral aspect. So along the radius would be the lateral epicondyle. Along the ulna would be the medial epicondyle. So fracture medial epicondyle is going to be ulnar nerve injury. Similarly, here in the lateral radiograph, this is the olecranon process that we are seeing here. Anterior one is the coronoid process. Now, how do we identify the carpal bones? So we all know the mnemonic, she looks too pretty, try to catch her. Remember that she looks too pretty is the proximal row, try to catch her is the distal row, and this is from the radial side to the ulnar side. She looks too pretty, try to catch her. Right, so starting from the radius to the ulna, radius wider bone, ulna slender bone. The proximal row, she looks too pretty, try to catch her. The one which is the largest carpal bone there is the capitate. It is the first to ossify. This round structure here is the hook of Hammett, fracture of which leads to ulnar nerve injury. Again, we have the Guillon's canal there. Then it is the scaphoid fracture, which is what leads to the anatomical snuff box tenderness towards the radius. Kinbox is the Lunetka osteochondrosis. Next one that we have here is tarsal bones. How do we identify? So in the tarsal bones, talus T is the one which articulates with tibia to form the ankle joint. So on the medial aspect, tibia ke side mein is where we have the talus. Talus ke baaju mein on the lateral side is the calcaneum. And talus ke aage the nerve shaped, boat shaped bone is the navicular. Okay, that is the navicular. And this joint here is the talocalcaneonavicular joint. In front of calcaneum, we have cuboid on the lateral side adjacent to the fifth metatarsal. So this is how you would identify the tarsal bones. Remember, in front of talus on the medial side, we have the navicular. So these are some of the important must-know radiographs that we should be knowing. Now coming to how do you differentiate scurvy from rickets on X-ray. So scurvy basically is vitamin C deficiency. This is vitamin D deficiency. No vitamin D, no calcium. No calcium means no white line of Frankel in rickets. While in scurvy, we do have this white line of Frankel which is present. In rickets, the white line of Frankel is present in healing rickets. When the vitamin D calcium is coming back post-treatment, then is when we see the white line of Frankel. So for response in rickets, basically we do the X-ray to look for this appearance of the provisional zone of calcification. Scurvy, the classical thing that you should be looking at is the epiphysis, which has the ring appearance. Ring epiphysis, which is called as Wimberger's ring, is what we see here. Adjacent to the white line of Frankel, that black zone is the tremor field zone. Okay, that is called as the tremor field zone. Apart from that, in scurvy, we have the spur-like thing which is called as the Pelton spur. The cortex is the pencil-thin cortex. And what we might also see, like in scurvy, we have a lot of bleeding. There can be subperiosteal hemorrhage as well, which can lead to pain. And that is why the patient can have pseudo-paralysis. Because of the pain, the patient is not able to stand and walk. In rickets, it's a calcification wala problem. So there's widening of the provisional zone of calcification. And what we see is with the weight bearing, the soft bones, they give way. So there is splaying, there is concavity, there is cupping, and there is irregular margin. That means there is fraying. So splaying, cupping and fraying is what we see with rickets. Now going to this one, this is again scurvy ka image, subperiosteal hemorrhage, white line of Frankel, tremor field zone, Wimberger's ring is what we see there. Osteomalacia is vitamin D deficiency in adults, and what do we see in osteomalacia are these looser zones, milkman's fracture or pseudo fractures, which are actually like stress fractures, and they have the sclerotic margins. The shape of the pelvis here is this triradiate pelvis. We see triradiate pelvis, and the shape of the vertebra, because of the soft bones, it is the codfish vertebra that we see here. So triradiate pelvis in osteomalacia. Where do we see champagne glass pelvis? Remember champagne glass, CH. Champagne glass pelvis is seen in achondroplasia. Achondroplasia, one of the causes of short stature. So we have this champagne glass pelvis that we see here. The iliac blades have the tombstone iliac blades. Tombstone iliac blades is what we see here. And we have the trident hand or the starfish hand. The increased separation between the middle and the ring fingers, that is the trident hand, is what we see here. Codfish vertebra we saw in osteomalacia. Remember, codfish vertebra, the biconcave vertebra, is seen in osteoporosis as well. Osteoporosis, again the bones weak here, the weight bearing causes decreased height, and the biconcave, the codfish vertebra. And how do we diagnose osteoporosis? Is by looking at the bone mineral density, which is measured by this, which is DEXA. Right, this is a DEXA scan. And here the bone mineral density according to WHO, normal is up to -1 standard deviation. -1 to -2.5 is osteopenia, and it is more than, like it is less than, when the decrease is even more than -2.5 standard deviations, then it is osteoporosis. Now, what is the T score and what is the Z score? So according to WHO, osteoporosis is defined as T score less than -2.5 standard deviation. Remember, osteoporosis has T in its spelling, so it is T score. And what is T score? So remember, T for 30-year-old. So when you compare the bone mineral density to a young adult, it is T score. When you compare with the same, equal to, and you connect it, it becomes a Z. Z matlab equal age wale se if you compare, then it becomes the Z score. What else can we use for osteoporosis is quantitative CT. And remember that all biochemical parameters are normal here. Calcium, phosphorus, alkaline phosphatase, everything is normal in osteoporosis. Now coming to acromegaly, that is increase in growth hormone. So increase in growth hormone, growth of the bones, the soft tissues is what we see. So the terminal phalanx, the distal phalanx ka overgrowth, that gives this appearance of the phalanx, which is called as spade phalanx, is what we see here. The increased heel pad thickness is another finding that we see in acromegaly. And we also see the enlargement of paranasal sinuses, the prognathism, all those are features of acromegaly. Next one, hyperparathyroidism. Now parathyroid causes subperiosteal bone resorption, and the first X-ray that we should take to look for the bony changes is the X-ray hand. Because classically the resorption starts in the middle phalanx, index finger is where it starts. Now what do we see here is, look at this subperiosteal resorption, the concave margin of the bone. Normally the bone should be flat, so the resorption happening there. What appearance of the skull do we get here? This is called as salt and pepper appearance, or it is also called as pepper pot appearance. The tiny lytic lesions, they give the salt and pepper appearance. So remember, pepper, P for parathyroid. What do we have here? The bony lesions that we see here, which look like a tumor. This is called as Brown's tumor. Okay, this is Brown's tumor, which is seen in primary hyperparathyroidism more commonly. Next, what we have is in secondary hyperparathyroidism, basically which is seen in renal failure. Remember, we have Rugger-Jersey spine. So R for R, renal osteodystrophy, Rugger-Jersey spine, which has those alternate the end plate sclerosis. And also we see chondrocalcinosis in secondary hyperparathyroidism. Chondrocalcinosis is also seen in pseudo gout. Okay, pseudo gout. Now coming to the various skull appearances. First one, the one that we saw just now, the salt pepper appearance, the tiny lytic lesions, the tiny lytic lesions there, they give the salt and pepper appearance in hyperparathyroidism. When you see a lytic lesion in the skull, which has this beveled margin and which has a button sequestrum. Within the lytic lesion, you can see that white area within, that is the button sequestrum. So these are findings of Langerhans cell histiocytosis. And remember, in the vertebra, it can also cause vertebra plana. The entire collapse with a flat vertebra, vertebra plana. When you see the lytic lesions which are very well defined and larger, almost of the same size in an elderly patient with bone pains, think of the punched out or the raindrop lytic lesions of multiple myeloma. What do we see here is the crew cut or the hair on end appearance of the skull, which is suggestive of increased hematopoiesis secondary to hemolysis. So this is seen in hemolytic anemia like sickle cell anemia, thalassemia, G6PD deficiency. Next, these are the findings in Paget's disease. Paget's has both a lytic phase, a blastic phase, a mixed phase. So it can give a lytic lesion like this, a very well defined lytic lesion which is called as osteoporosis circumscripta, or it can also give the cotton wool skull where you see those white areas in the skull. The cotton wool skull is also in Paget's. Now the age group at which Paget's presents is generally an elderly patient. The hallmark of Paget's is cortical thickening. So the cortical thickening can cause a cranial nerve foramina compression and the nerve palsies, like it can cause SNHL, right? So if you have an elderly patient with SNHL and heart failure, you should think of Paget's. So what are the other skeletal findings in Paget's? The long bones, the lytic lesions, they grow from one end and they go towards the diaphysis. As they grow towards the diaphysis, giving the candle flame sign or the blade of grass appearance. In the vertebra, we said that Paget's causes cortical thickening. So look at the cortex which is thickening, giving the picture frame vertebra. So remember P for P, picture frame is seen with Paget's. Paget's can also show ivory vertebra, absolutely white vertebra, white like ivory because of the blastic phase. Where else do we see ivory vertebra? It is also seen in lymphoma and of course the blastic metastasis of the bone like in CA prostate. In the nuclear scan, Paget's gives this Lincoln sign and the Mickey Mouse sign. The Lincoln sign is the increased uptake in the mandible like the beard of Abraham Lincoln, and the Mickey Mouse sign is the increased uptake in the vertebral body and the posterior elements also. So that gives the Mickey Mouse sign on the nuclear scan, that is the bone scan. And remember that in Paget's, the biochemical alteration that we have is only the ALP significantly increases, calcium phosphorus is normal. Next one, now do not confuse the picture frame vertebra with the bone within bone appearance. Now look at this bone within bone, the cortex is normal. Inside that we see another piece of bone. So this is bone within bone appearance which is seen in osteopetrosis. Okay, this is seen in osteopetrosis which is also called as marble bone disease. So here in osteopetrosis we have diffuse sclerosis with multiple fractures. Another condition where you can have multiple fractures, especially in antenatal ultrasound also, in fetus as well. Remember osteogenesis imperfecta, which will have association with blue sclera is what can be given in the question, and also otosclerosis is associated. What is this vertebral appearance here? The sclerosed end plates. So white, black, white appearance, the striated appearance like the rugger jersey. This is the rugger jersey spine, which is seen with R for R, renal osteodystrophy. Next one, what you see here is the H-shaped vertebra. So H-shape is very similar to biconcave, but the difference is here the central end plate depression is more, and this is seen with sickle cell anemia. This is also called as Lincoln log vertebra. So the infarct in the sickle cell anemia causes this central end plate depression first. In the later stages, then it can go to biconcave or the codfish vertebra. Next one, vertebral hemangioma. What do you see radiologically? So we see the polka dot appearance, the corduroy appearance and the jail bar appearance. You can remember as hemangioma is like Hema Malini. So look at this Hema Malini wearing this polka dot wala top and the corduroy jeans and going to the jail. So polka dot, corduroy and jail bar appearance in Hema, that is hemangioma. So what happens with hemangioma is you will see this prominent vertical trabeculations like the jail bar or corduroy. When you take a cross section, the lines look like the dots. So that gives this polka dot appearance. So polka dot, corduroy or jail bar appearance in vertebral hemangioma. Now coming to trauma. And talking about the various Scotty dog appearance. So where do you see the Scotty dog appearance? Scotty dog appearance is seen in normal lumbar spine X-ray oblique view. Scotty dog with a collar is what is abnormal. The collar tells me that there is a fracture in the neck of the dog, and that's why we have put a collar. So that is fracture. That means lysis. So remember that with collar it is seen in spondylolysis. Now when the neck is fractured, the head becomes unstable and it can get beheaded. So when it gets beheaded, then it is called as listhesis. Listhesis means the slipping of the head. So beheaded Scotty dog is seen in spondylolisthesis. Let's have a look at the images. So look at this radiograph here, the oblique view of the lumbar spine. Look at this normal dog appearance here. Look at the dog appearance here. So we have this superior articular process, the inferior articular process, and connecting the two is the neck of the dog, which is pars interarticularis. Now when there is a fracture in this neck, the pars interarticularis, that is when we get the Scotty dog with a collar. And when this bone gets slipped ahead, you see the alignment is gone. This bone is not in alignment with the sacrum. It has gone in the front. Then it is called as listhesis. And it has beheaded Scotty dog appearance in the oblique view. When there is severe L5S1 spondylolisthesis, on the frontal radiograph, we see this sign, which is the inverted head of Napoleon, which is called as inverted Napoleon hat sign. So look at the lateral radiograph. The L5 vertebra has come entirely in front of the S1. Severe listhesis, inverted Napoleon hat sign. Next one, in shoulder dislocation. With shoulder dislocation, we see this light bulb sign. What is the light bulb? Now, normally you should see this overlap of the humerus with the glenoid and forming this crescent or half moon here. When this is lost, the bones are not overlapping. It suggests the light bulb appearance, and it is seen in posterior dislocation of the shoulder. Coming to hip dislocation, which is anterior, which is posterior, has been asked previously. So remember that anterior dislocation has Faber position of the limb, flexion, abduction and external rotation. Father, that is like father, paternal, P, father is in posterior, that is flexion, adduction and internal rotation. So what do we see here is the femur is going out, that means it is abducted, and that is why Faber anterior dislocation. The femur here is coming medially, that means it is adducted farther, so this is posterior dislocation of the hip, which is the most common dislocation in the hip seen in dashboard injury as well. Now talking about the very important topic here, that is bone tumors. Now in bone tumors, MRI is the investigation of choice to look for the extent of the bone tumors, to look for the skip metastasis. Except for osteoid osteoma, where CT is the investigation of choice. We have read that time and again. Now, the most important and the confusing bone tumors here. How do you differentiate GCT from ABC, that is aneurysmal bone cyst, and chondroblastoma? So, this is what I have summarized here. Now, remember the tumors occurring in the epiphysis. It is ECG, that is in the epiphysis we have the chondroblastoma and the giant cell tumor. The difference is, remember, giant cell tumor occurs in a giant person. That means in an adult person after the fusion of the skeleton. Chondroblastoma, like blastomas, occur in the childhood. So, chondroblastoma is unfused skeleton. So, on the other hand, exactly opposite of GCT. Now, fused and epiphysis is going to be GCT. Opposite of that, that is unfused and epiphysis. Epiphysis, another one is chondroblastoma. Unfused and metaphysis, completely opposite, is going to be aneurysmal bone cyst. So look at the tumors here. Expansile lesion with the soap bubble appearance involving the epiphysis going till the joint. Remember, giant cell tumor, giant goes till the joint. Fused skeleton, all this is giant cell tumor. Unfused skeleton, you see that gap there, the growth plate. And you have the epiphysis involved. Unfused epiphysis is chondroblastoma, which histopathologically has chicken wire calcification. Then you have this unfused skeleton again. The lesion is in the metaphysis, not the epiphysis. This is going to be aneurysmal bone cyst, which can also show the soap bubble appearance like GCT. Aneurysm tells you that there is something related to blood. So on MRI, it can show the blood fluid levels. Okay, it can show the blood fluid levels on MRI. What is the treatment for giant cell tumor? Another frequently asked question. It is extended curettage with grafting. It is curettage that is done for GCT. Going to the next set of tumors, the first one that you see here, the proximal humerus, again unfused skeleton, a central lesion with this fallen leaf sign. You see a fragment which is falling into the cyst. This is simple bone cyst, also called as unicameral bone cyst. Fallen leaf sign, also called as trapdoor sign. Like you can see, the proximal humerus is the most common site. So simple bone cyst is central. Aneurysmal bone cyst is eccentrically located. It is multiloculated. This one is uniloculated. When you have this sunburst appearance of the periosteal reaction with the osteoid formation, think of osteosarcoma. So remember SS, sarcoma has sunburst appearance. It is one of the malignant, the aggressive periosteal reaction. When you have this lamellated periosteal reaction, that is like this, like the onion peel, then we should think of Ewing's sarcoma. Ewing's is common in the child, like around 5 years of age, the first decade. Important, there is history of fever also here, so it mimics osteomyelitis, and there's a lot of swelling that is present, and this involves the diaphysis, that is the shaft of the bone, right? And remember for Ewing's, the CD marker, CD99, translocation 1122, all the double numbers 991122. Next, what are these tumors now? Now, what do you see in the first one here is there is an outgrowth from the bone continuous with the bone cortex. So, outgrowth is like exostosis, that is osteochondroma. Exostosis is osteochondroma. So, from chondroma we know that it has a cartilage cap, the thickness of which is important to be measured to look for malignant change. When it becomes malignant, it becomes more than 2 centimeters. Some books also mention as 1.5 centimeters. Multiple osteochondromas are called as hereditary multiple exostosis, or it is also called as diaphyseal eclasis. Diaphyseal eclasis. Next tumor here is a cortical based tumor, cortical thickening with the central nidus. So remember that within the thickening we have the nidus, that is O and O. So this is OO, that is osteoid osteoma. And the patient keeps saying OO because the patient has a lot of pain, which is worse at night. Right, so there is night pain relieved by aspirin. That's a classical history here in osteoid osteoma. It is because of the prostaglandins from the nidus, and that is why relieved by aspirin. And the treatment here is radiofrequency ablation. We ablate the nidus, which is the cause of the pain. So for osteoid osteoma, the investigation of choice is CT. When you have the lesions, the bony lytic lesions in the small bones of the hand, then you should think of enchondroma. So remember enchondroma starting with E, the 5th alphabet, and involving the 5 fingers, that is enchondroma. And when you have multiple enchondromas, then it is called as Ollier's disease. When you have enchondromas plus hemangiomas, then it is called as Maffucci syndrome. So remember it as all ears is all E. All ears is all E. Maffucci's, M for M, is a mix of enchondromas and hemangiomas. Next one here, when you have a lesion which is extending beyond the bone, involving the flat bone, and it has this popcorn type of calcification, then you should think of chondrosarcoma, especially in the elderly patient. So chondrosarcoma, like the chondroid tumors as popcorn calcification, extends beyond the bone. So that was the summary of the primary bone tumors. Now coming to the secondary, the metastasis. Vertebral metastasis give this winking owl sign. So in the vertebra, these rounded structures here, they represent the pedicles of the vertebra. When one of the pedicle is destroyed by the metastasis, so out of the 2 eyes, only one is present and open. So that looks like the winking owl sign. So winking owl sign is vertebral metastasis. Now, what is fibrous dysplasia? As the term says, dysplastic bone with fibrous material. So, that has ground glass matrix. So, there is bony expansion with the ground glass matrix, and the femur shows this Shepherd crook deformity. Recent NEET PG question. So, what do you see here? The femur is bent like this, like a shepherd crook is bent. Okay, like a shepherd crook is bent. So, fibrous dysplasia has this shepherd's crook deformity of femur. We have polyostotic fibrous dysplasia with precocious puberty, caffeole spots. These are features of McCune-Albright syndrome. Okay, these are features of McCune-Albright syndrome. Next one, coming to very favorite with the examiners, that is ankylosing spondylitis. A young male with low back ache, HLA-B27 positive. Think of ankylosing spondylitis. Ankylosing means fusion. Spondylitis means the spine inflammation. So, the entire spine gets fused, including the anterior, the posterior, everything. And spondylitis is inflammation, so it is inflammatory arthritis. So, it will have feature of morning stiffness. Morning stiffness indicates inflammatory arthritis. It starts with the sacroiliitis, and that is why the STIR MRI is the most sensitive investigation for ankylosing spondylitis to look for the early bone marrow edema, like you see in this case. Later on, what happens is, you see this fusion of the vertebra that is happening because of the formation of syndesmophytes, and there is this sign which is the dagger sign. What do we see is the dagger sign. The dagger sign, the white line in the midline, represents the ossification of the interspinous ligament. Now, you might also see the ossification like 3 lines in the vertebral bodies also. Then that is called as trolley track sign. Look at the fusion of all the vertebrae here by the formation of the syndesmophytes. Look at the fusion by the syndesmophytes formation. This is called as bamboo spine. What do we see here is the entire spine is fused. The vertebrae are fused here. Even the facet joints are fused. So, entire fusion, ankylosing spondylitis. What is the earliest X-ray finding of ankylosing spondylitis? Remember, it is the Romanos sign, also called as the shiny corner sign. So, we see this shiny, the sclerosis at the corner of the vertebra. That is what we see here. All these features are basically because of enthesitis. Okay, we see enthesitis in ankylosing spondylitis. And generally in the question, you are also given the history of red eye, because uveitis is the extra articular manifestation associated with ankylosing spondylitis. Now, how do you differentiate ankylosing spondylitis from DISH? That is diffuse idiopathic skeletal hyperostosis, also called as Forestier's disease. And here the age group is generally more, and it is just the anterior longitudinal ligament. Along that we see the flowing wax ossification is what we see here. So, anteriorly only there is this fusion that is present, like you see in this case. Posteriorly, you can see the facet joint space is maintained. Similarly, on the CT scan, look at the ossification, the fusion anteriorly. Posteriorly, there is a gap. That means there is no fusion there. Okay, so this is DISH. What happens in fluorosis? Fluorosis, you can see how are the bones appearing. Very white, very dense. So, there is osteosclerosis, diffuse osteosclerosis, causing the sclerosis, the ossification of the ligaments also. Like there is this interosseous membrane ossification. You can see the ossification of this sacrotuberous ligament also, going from the sacrum to the ischial tuberosity. Sacrotuberous ligament ossification also is seen. Now, going to the different arthritis. So, we have degenerative arthritis and we have inflammatory arthritis. Clinically, the most important point here, degenerative bone and tone joint gets more tired with activity. So, here the pain increases with activity. Opposite in inflammatory, the pain decreases with activity. It increases with rest, and that is why clinically in inflammatory arthritis we have morning stiffness is what we see there. Radiologically, degenerative arthritis, osteoarthritis is asymmetric involvement of the joint. There are osteophytes formation and there is sclerosis. Inflammatory arthritis, a lot of inflammation. We know that always there is swelling. It will cause erosions which are symmetric. Okay, it's symmetric involvement with erosions. In inflammatory arthritis, if it is only one joint involved, Then we think of infection, septic arthritis. If it is more than one joint involved, then thinking of rheumatoid arthritis, that is seropositive, RA factor positive, or seronegative spondyloarthropathy. The difference is in rheumatoid arthritis, there is no bony proliferation and the DIP is spared. In seronegative, there is bony proliferation which is present, like in psoriatic arthritis. And the distal, the DIP also is involved. Degenerative arthritis can be atypical also, which includes neuropathic, the crystal deposition and hemophilia. So let's have a look at osteoarthritis, that is the degenerative osteoarthritis. Knee joint commonly involved. So this is normal and this is osteoarthritic joint. Look at the asymmetric joint space narrowing. Look at the osteophytes formation and the sclerosis. The subchondral sclerosis is what we are seeing here. In the hand, the common joint involved by osteoarthritis is the first CMC joint. The first carpo-metacarpal joint is commonly involved. The nodes that we can see in the fingers, proximal are the Bouchard's and distal are the Haberden's. So remember, it is HDBP, high definition BP. That is, Haberden's are distal and Bouchard's are proximal. Now, when you see the erosions in osteoarthritis, which gives the seagull or the gull wing appearance, this is a feature of erosive osteoarthritis. The atypical form which gives the seagull or the gull wing appearance in erosive osteoarthritis. Now, going to rheumatoid arthritis, it is symmetrical involvement. Proximal joints are involved and there is no bony proliferation. Because of the inflammation, the resorption, there is osteopenia. Juxta-articular osteopenia is what we see frequently. The first joints to be involved are the metacarpophalangeal joints. So look at this osteopenia around the metacarpophalangeal joints. Rheumatoid arthritis classically spares the DIP. It does not involve the DIP. The deformities that we can get, the swan neck deformity and the Boutonniere deformity. Swan neck is the DIP flexion, the PIP extension. Opposite is the Boutonniere. It is the PIP which is flexed. So when you have the DIP flexion, think of swan neck. PIP flexion, it is Boutonniere deformity. Now going to psoriatic arthritis. In psoriatic arthritis, psoriasis involves the skin also and the nail also. So those changes will also be present. And remember, P for P, it has the penicillin cup appearance. Penicillin cup is this pointed appearance of the phalanx going into the distal phalanx. That is the penicillin cup appearance. The last stage is the arthritis mutilans. And psoriatic arthritis has a tendency to involve along the one digit, that is called as ray distribution, and it causes significant soft tissue swelling and gives rise to sausage digit. Any joint practically can be involved by psoriatic arthritis, including the DIP like we are seeing here. Coming to gout. Gout is GTO, that is the great toe. The first metatarsophalangeal joint is the most commonly involved. Alcohol ka history, aspirin ka history is there. And in gout, we see the erosions which have overhanging edges. So we see the erosions which have this overhanging edges. These are called as rat bite erosions, also called as the Martel sign or the G sign. In gout, basically there is uric acid deposition, and we know that uric acid can be identified by dual energy CT. Versus pseudo gout, which involves the larger joints like the knee joint. And remember that in pseudo gout, there is chondrocalcinosis. You can see this meniscal calcification here, suggestive of chondrocalcinosis, pseudo gout. Remember, we also saw chondrocalcinosis in secondary hyperparathyroidism. Now going to Charcot's joint, which is basically the neuropathic joint. So because of the loss of sensation, the nerves being damaged like in diabetes, leprosy, we see this neuropathic joint and it has 6 Ds. There is joint distension, there is destruction, debris are there, dislocation is there, deformity is there, and remember the density of the bone is increased or normal. There is no osteopenia here. And we see a lot of, if you take the radiograph, it looks very, very bad. But because it's neuropathic, the patient might not have the symptoms. So it actually looks very bad, but the patient might not have the symptoms. That is classical of neuropathic or Charcot's joint. And you see this pointed bones, like this is called as linked candy appearance. Okay, so we see this licked candy appearance. Leprosy is one of the causes of that. Now coming to infections. Osteomyelitis, the most sensitive investigation is MRI. In chronic osteomyelitis, the patient presents with discharging sinus. What is the sequestrum? Sequestrum is the dead bone. And dead bone is radio opaque because there's no blood supply, so there's no resorption. So look at this image here. The white bone in the center, that is the sequestrum, which is the dead bone, which is radio opaque. Now, surrounding that, the white area that we have, the new bone, the periosteal reaction, that is the involucrum. So, involucrum, involuting, that means the healing, like the uterus involutes post-delivery. The opening in the bone is the cloaca. Cloaca we know is the opening, and that can go till the skin surface and form the discharging sinus. So, that is chronic osteomyelitis. Subacute osteomyelitis, one of that is Brody's abscess. So, Brody's abscess classically has the sclerotic margin. It is an oval lesion along the axis of the bone. Next, what are we seeing here? This is the MRI spine with the black bone cortex, T2 weighted with the white CSF. And look at this involvement in the spine. It is 1, 2, not just one vertebra involved. The intervertebral disc is also involved. So, whenever the intervertebral disc is involved, we should think of Pott's spine, because the most common Pott's spine is paradiscal type. It involves the IVD and the adjacent vertebra, right? So, this is Pott's spine, which is actually involving the intervertebral disc and causing this collection, the abscess formation, leading to the cord compression. Next, avascular necrosis. The most sensitive investigation again here is MRI. If it is bilateral, then we can do bone scan. And with avascular necrosis, again the bone will become dead, the bone will become radio opaque. And what do we see is the shape of the femoral head is gone. If there is necrosis, it becomes collapsed in the late stages. There is sclerosis and there is this crescent sign that we see in avascular necrosis, right? So remember, there is crescent sign and there is double line sign that we see on MRI. Okay. Now this is the image that was asked in the recent NEET PG 23 exam, but the image actually mentioned that it is bipartite patella. And there was only one option which said it is bipartite patella. So actually the answer was given in the image. So always hunt for the clues in the image. Now bipartite patella actually looks like fracture patella. But the difference is here there would be no history of trauma, no history of pain. And generally this is bilateral because bipartite means the patella is in two parts. It is a problem with the fusion of the patella. And that's why the site is classical. You see it in the superolateral aspect. So this is the lateral aspect because I see the fibula here. And there is this non-fusion. There is this accessory part there which has not fused. And what do you need to do is you need to take the x-ray of the other knee, because generally this is bilateral. Okay, generally this is bilateral. Now since we are at this radiograph, I remember another question from NEET PG 23. The question was, fracture at which of these sites in the radiograph will cause foot drop or inability to dorsiflex? Now foot drop, that is inability to dorsiflex, is because of the common peroneal nerve injury. And where is the peroneal nerve? Around the fibula neck. So if there is a fracture here around the neck of the fibula, then it will be common peroneal nerve injury leading to foot drop. Okay, that is inability to dorsiflex. Right. So, hello friends. Now let us learn about the OBGY and breast imaging. So, looking at the modalities that are used. So, for obstetrics and gynecology, the main workhorse of investigation is ultrasound and MRI. And we use hysterosalpingogram basically for looking at the tubal patency in a patient of infertility to rule out tubal block. For breast imaging, we have mammography, ultrasound and MRI. We will have a look at these investigations as we go ahead. So here what we have, the first investigation is hysterosalpingogram, HSD, which is basically the contrast X-ray for the uterus and the fallopian tubes. So what do is we cannulate the cervix and we push the contrast because it's an X-ray based modality. So we have iodinated contrast which is used. The contrast goes from the uterine cavity into the fallopian tubes, and if the tube is patent, the contrast comes out into the peritoneum. So when the spill of dye is present, It is normal. It suggests that it's a patent tube. Wherever there is a block, we will not see the contrast going ahead. Like in this case, we are seeing right cornual block itself. The entire tube is not seen. The block is at the level of the uterine cornu. So does HST have radiation exposure? Yes, because it's a contrast X-ray. On what day do we prefer doing this? Around day 9. Definitely not after day 10 or day 14, because we have the 10-day rule for females of reproductive age group. Do investigations which have radiation exposure in the first 10 days. We don't do it on day 3, day 4, day 5 because it's still the menstrual phase and the endometrium has not healed yet. So normal hysterosalpingogram will have the spill of the contrast. Now coming to ultrasound, we can do ultrasound pelvis trans-abdominal sonography or trans-vaginal sonography. Trans-abdominal means over the abdomen. The difference in the procedure is for trans-abdominal, the bladder has to be full so that the urine in the bladder serves as the transmitter of the sound and we see the uterus behind very well. In contrast, for trans-vaginal sonography, the urinary bladder should be empty because we are going trans-vaginal, so we don't want the distended bladder to compress and interfere with the probe insertion, right? So remember, here the bladder empty, here the bladder full. The trans-abdominal sonography has this trapezoidal shape and the trans-vaginal has this circular shape here. Now going to the normal findings in early pregnancy. So in early pregnancy, of course, the investigation of choice is ultrasound, not CT because it has radiation exposure. In ultrasound, what is preferred, TAS or TVS? It is trans-vaginal sonography because it gives higher resolution images. What is the first thing to appear in pregnancy? Is the gestational sac, right? The first thing is the gestational sac. So in the thick endometrium, what we see is the small gestational sac. With the period of time, the period of pregnancy, the gestational sac enlarges and then within the gestational sac comes the yolk sac. So this one which you are seeing here, this bigger one is the gestational sac. The smaller one inside that is the yolk sac. So the appearance of the yolk sac is the first definitive sign of intrauterine pregnancy, not the gestational sac, because gestational sac can be pseudo-gestational sac also like an ectopic pregnancy. Now after the yolk sac, then we have the embryo, the fetal pole and the amnion coming in, and what gives the double bleb sign here is these two circular things that you see here. One is the yolk sac and the other is the amnion. So remember that the double blab is formed by the yolk sac and the amnion, as is one of the previous INI-CT exam. Okay, that gives a double bleb sign. Once the fetal pole is there, you want to see for the cardiac activity. Do not use Doppler in the first trimester. It can damage the embryo. We use the M mode of ultrasound to look for the cardiac activity and to look for the fetal heart rate. Now, so what is this in the first early pregnancy? This is the yolk sac and the outer one is the G sac. And this is the double bleb sign that we have already seen. Now, ectopic pregnancy, how do we identify? So there would be a pseudo-gestational sac or no gestational sac in the uterus. We might see an adnexal mass basically. Most common site there, adnexal mass. And when we do Doppler, you see this ring of fire appearance. The ring of fire appearance is seen with ectopic pregnancy. Next one, in twin pregnancy, where do you see the T sign and the lambda sign? So remember that lambda, the mnemonic here is, remember, laddu. That means lambda sign is seen in DD, that is dichorionic diamniotic pregnancy. T sign, remember T, the most famous T wala in our country, our respected Prime Minister Modi ji. So remember T is Modi, that is monochorionic diamniotic. Monochorionic diamniotic gives the T sign. So this is where you see the monochorion, the diamnion, the separating membrane. And this is the lambda sign which is seen with dichorionic diamniotic. So look at this one. This is the T sign here. And the thick membrane tells me that this is dichorionic diamniotic. That gives the lambda sign. Molar pregnancy, what do we see in a complete mole? Clinically, the patient presents with, from the vagina, there are clusters of grapes-like thing coming out. When we do ultrasound, we see this vesicles thing, the cystic areas throughout, no fetal parts. This is called as snowstorm appearance. Very, very important. So in the uterus, we only see the cystic spaces and nothing else. And the treatment is going to be suction and evacuation. This has high beta HCG levels which can stimulate the ovaries, and it can also lead to theca lutein cyst in the ovaries, which by themselves do not need anything. When we do the suction evacuation for molar pregnancy, beta HCG comes down, the theca lutein cysts go away spontaneously. NT scan. NT is the nuchal translucency scan, which is done in the first trimester around 11 to 13 weeks when the CRL is between 45 to 84 millimeters. And increased NT, the average for our exam, let's take it more than 3 millimeters is abnormal, and it is associated with Down syndrome, congenital heart defects, other chromosomal abnormalities. It is not specific for Downs. In NT scan, we also look for the presence of the nasal bone. So we should see this nasal bone which is present. If it is absent, again it increases the chances of Down syndrome. And in the combined first trimester screening, we combine it with the parameters. The dual marker test is what we do in the first trimester. The dual marker is the beta HCG and the PAPA. Remember, it's the beta and the PAPA in the first trimester. Out of that, what increases in Downs? HCG is high. H for high, HCG is high. PAPA goes down in Downs. So increased NT, we should evaluate further. We should confirm by karyotyping to rule out Down syndrome. Anencephaly is the earliest anomaly that can be identified on ultrasound as early as 10 to 11 weeks. And what do we see? The sign that we have is the frog eye sign, because anencephaly, the absence of the cranial wall, the brain structures, that gives the bulging eye appearance. So look at this one. These are the eyes here, and you have this part of brain parenchyma which is just floating around. The frog eye sign, also called as the Mickey Mouse sign, is what we see here. So again, this is the anencephaly here. You don't see the white cranial vault here. The white bone is not seen there. Another image of the frog eye sign. We don't see the brain parenchyma, the cranial vault here. For anencephaly, of course, we have to do MTP because it is not compatible with life. So what are the other signs that we see in neural tube defects meningomyelocele? So the sign that we see is the lemon sign and the banana sign. The meningomyelocele, the neural tube defect causing the downward pull on the brain structures. The frontal bone goes inwards and it gives the concavity of the frontal bone, that is the lemon sign. What also happens is with the down growth, the posterior fossa gets crowded. The cerebellum curves around the brainstem like a banana. So that gives the banana sign and the lemon sign in neural tube defects. Next one, how do we differentiate omphallocele from gastroschisis? Now, omphallocele, when I write O, omphallocele, it is a complete circle. So that means it has a membrane surrounding. When I write G, gastroschisis, remember it has a defect. That means there is no encircling membrane there. Omphallo, related to omphalitis, umbilical cord. So remember, it has at its center, the umbilical cord stump is attached to it. It is right in the midline. So omphallocele will have this membrane. This is a defect in the abdomen, the contents going out, and it has a membrane here. And at the center, it has this cord insertion. In contrast, gastroschisis, this is the umbilical cord, and the gastroschisis is adjacent to the umbilical cord. That means it is not in the midline and it does not have the surrounding membrane. Next one, where do you see the Spaulding sign? Now, what is the Spaulding sign? Spaulding sign is this overlap of the skull bones that you are seeing here. One bone overlapping over the other, suggestive of maceration that has occurred in the fetus. So it is suggestive of intrauterine death. The earliest sign is the Roberts sign, where you see intracardiac gas shadow is what you see in intrauterine death. Next one, coming to obstetric Doppler, which is done to look for IUGR, the blood supply to the fetus as well, or whether there is any IUGR. So we do obstetric Doppler in the third trimester. Now, umbilical artery Doppler. Basically, the umbilical artery normally should have high diastolic flow. It's a low resistance vessel. When the resistance increases, the diastolic flow goes down, and that is why the S/D ratio, systolic by diastolic, increases. With increased severity of IUGR, the diastolic goes down, then it becomes absent, and then it goes below the baseline. There is reversal. So reversal is the severe IUGR. It suggests that there is impending death of the fetus and we need to do immediate termination of pregnancy, right? So this is umbilical artery. Similarly, uterine artery also is a low resistance in pregnancy. It should have high diastolic flow. There should be no notching. Notching indicates that it's a high resistance vessel. So if you see this notch is present in the uterine artery, even after 22 weeks of gestation, then it is abnormal. Up to 22 weeks, it is normal because by then the trophoblastic reaction, the spiral artery scar has not occurred. So persistent notching tells you that there's a high risk of preeclampsia in this patient. The normal uterine artery should have this high diastolic flow without any notching. Now coming to the ovarian abnormalities, PCOS. PCOS basically has bulky ovaries with the volume more than 10 cc. Polycystic, actually you have the polyfollicles. So in PCOS what happens? There is no dominant follicle. All the follicles are less than 10 mm in size and they are arranged in the periphery like the string of pearls or the necklace sign. So what does it give is the string of pearls or the necklace sign is what we see here. And along with that, the central stroma is increased and echogenic that pushes the follicles to the periphery. So these are the findings in PCOS versus if I have to differentiate it with ovarian hyperstimulation syndrome, where you would have the background history of a patient who is having infertility, planned for IVF, so drugs which are causing ovarian hyperstimulation. So here you would see large follicles which are large more than 10 mm. Both the ovaries will have large follicles. They will not have the increased central stroma. So large follicles without increased central stroma is what we would see in OHSS. Similarly, we would see in theca lutein cyst also, which we discussed in molar pregnancy. But here the history would be beta HCG positive because it's a molar pregnancy. Right, so that's the difference between OHSS, theca lutein cyst and PCOS. Now coming to uterine anomalies, which are one of the favorite topics in the recent exams. So uterus basically develops from Mullerian duct. So Mullerian anomalies, in the embryology we have two Mullerian ducts which develop. They come in the midline, the septum goes off and that gives a single uterine cavity in the midline. If the two ducts are completely separate, no fusion at all, then the abnormality that it gives is uterus didelphys. So no fusion is didelphys. Remember, it is not bicornuate. So didelphys will be entirely separate like you see here. Two uterus, two cervix separate. We will need two cannula to visualize the two uterus. When you have the partial fusion, the lower part is fused, the upper part is unfused, then it gives bicornuate uterus. So partial fusion is bicornuate. Because the fusion has not complete, the two cornu will be widely separated. So look at this, the widely separated cornu with a wide angle is what we have in bicornuate uterus. In septate uterus, the fusion has complete. So the two cornu are close together. But what do we have is there is a separation, a septum which is present. So basically it also appears like bicornuate on HSG. But the two cornu are close together. But remember, this is not a foolproof thing to make a diagnosis of septate and bicornuate. So HSD actually is not a very good investigation for uterine anomalies. 3D ultrasound, MRI are better. The best non-invasive investigation is MRI. The gold standard investigation is combination of laparoscopy and hysteroscopy. Because laparoscopy will help us evaluate the outer surface of the uterus. Hysteroscopy will help us evaluate the inner surface, the endometrial cavity. Right, so a combination of both is the gold standard. And what is this one? This is the unicornuate uterus, where only one duct has developed and it is deviated to one side. So unicornuate uterus, also called as banana-shaped uterus. It's a banana uterus. So how do we differentiate septate from bicornuate on MRI? Now understand the difference. Bicornuate uterus is a fusion abnormality. So the outer surface is also separate. The inner surface is also separate. In septate, the fusion has occurred. So it has a S for S. Remember, it has a smooth outer surface. It is the endometrial cavity which is separated. So look at this one. What do we see here? The first image, look at the HSD. You have like bicornuate septate jaisa appearance. To confirm, we do MRI. Look at the MRI. The outer surface is smooth. The inner endometrium is separate. So smooth, S for S, is septate uterus. Here again in HSD, bicornuate septate, do a MRI. What do you see is the outer surface is also separate, the inner surface is also separate. So remember, bicornuate is by. Bahar bhi by, andar bhi by, that means two outside and inside also. While septate is smooth outside and two different endometrial cavities. That is how we differentiate septate and bicornuate uterus. Now next, coming to the next pathology, endometrial polyp, which is within the endometrial cavity. So it is endometrial like endometrial gland ka polyp. So it will be hyperechoic. Any polyp has a vascular stalk. So when you do Doppler, what sign you would see is the feeding vessel sign. So look at this image here. We have this vessel which is supplying this lesion, feeding vessel sign, suggestive of endometrial polyp. Look at the uterus here. Look at the endometrial cavity and look at the echogenic lesion within the endometrium. Do a Doppler, you would see the feeding vessel sign. The best investigation to differentiate whether this is polyp or this is submucosal fibroid is saline infusion sonography, where we instill saline into the endometrial cavity and we distend the endometrial cavity. So we get to see that this lesion actually is within the endometrial cavity. Fibroid will be outside the endometrial cavity and it would be hypoechoic because it is muscle. Leiomyoma, muscle is hypoechoic. Next one, adenomyosis, where the patient presents with dysmenorrhea, menorrhagia. Adenomyosis is endometrial invasion into the myometrium. So you would see those hyperechoic endometrial glands in the myometrium. Same thing in the MRI. You see the bulky uterus and you see those hyper intense endometrial glands in the myometrium. This is called as salt and pepper appearance. There is thickening of the junctional zone in adenomyosis. On ultrasound, what do we see is the bulky uterus with a lot of these linear shadows coming in, which is the vertical lines. This is called as Venetian blind effect or the Venetian blind sign, which might also be seen in cases of fibroid also. Next one, coming to ovarian dermoid. Classical radiological appearance, because dermoid contains fat and calcification. That means it can have tooth, it can have a bony structure. Fat will be dirty black on CT, calcification will be white. So look at this one, a pelvic lesion having the white calcification, the dirty black fat. So when you have a pelvic lesion with a fat and calcification, both think of ovarian dermoid or teratoma, which can undergo torsion. On ultrasound, because it is fat containing, it will appear hyperechoic. The other sign in dermoid on ultrasound is the tip of iceberg sign. So we get this posterior acoustic shadowing, which does not allow the behind part of the dermoid to be seen. We can only see the surface. So that's the tip of the iceberg sign. The hair plugs in the dermoid, they can give this dot and dash sign. And we also see this hyperechoic, the Rokitansky protuberance, which gives the posterior acoustic shadowing. So this is ovarian dermoid. The negative HU value on CT helps us to identify the fat in that. So now we are going to learn about breast imaging. So the modalities we know in breast imaging are mammography, ultrasound and MRI. Mammography is X-ray of the breast. It is preferred in elderly female, not in young female because of the dense breast in the young female. So everything looks white in a young female mammography. So how does a mammography machine look like is, it has this compression plate because compression, like you see here, is a must in mammography. Not for any other reason but to make it homogeneously dense and to decrease the thickness so that the X-ray penetration and the visualization is better. So mammography has radiation exposure which is approximately 20 to 25 chest X-rays. Now in mammography, for every breast, we take at least two perpendicular views, that is the craniocaudal, right? Craniocaudal and the mediolateral oblique. We take the mediolateral oblique so that it includes the axilla as well and we can see the axillary lymph nodes as well. So this one is the craniocaudal view and this one is the MLO view, which includes the axilla also. So MLO view has a better coverage as compared to craniocaudal view. Now, breast abscess is a condition where mammography is contraindicated. So we said that in mammography, compression is a must. So any condition where breast cannot be compressed, that is acute painful condition, mammography is contraindicated, like mastitis, breast abscess. So what is the investigation of choice in breast abscess? It is ultrasound. Breast abscess is common in lactating females. So if you have a patient or lactating mother with a breast lump which is painful, which is tender, there is fever, the investigation of choice is going to be ultrasound, because ultrasound will show the abscess with the echoes and debris within, and the type of vascularity you see is peripheral vascularity. So it helps us identify that it's not a solid lesion, it's a cystic lesion with pus with echoes within. Now we have for the breast lesion evaluation, we have BI-RADS. What does BI-RADS stand for? Breast Imaging, Reporting and Data System. Remember, BI-RADS stands for breast imaging. We image the breast, we make the report, and data system. It is not diagnosis system. And this BI-RADS is applicable to all the modalities, that is mammography, ultrasound and even MRI. So we have different descriptions for each of these modalities. The BI-RADS 5 is the one which is highly suspicious for malignancy. Normal mammography is BI-RADS 1. 1 is rhyming with none. So remember, none abnormality is BI-RADS 1. What is BI-RADS 6? A histopathologically proven breast cancer patient, already a known patient. It is a BI-RADS 6. So what features make a breast lesion as BI-RADS 5 on mammography? Very, very important. Remember, it is microcalcification and not macrocalcification. It's a dense lesion with architectural distortion and microcalcification. Very, very important. So if we see that, we have to do biopsy to confirm that it is breast cancer. Now, the ultrasound features of breast cancer are, it has spiculated margins and the lesion is taller than wider. Why? Because the taller than wider lesion tells you that it is invading the various planes and it is going from one plane to the other. A wider than taller tells you that it's in the same place and it is extending in the same place. So taller than wider means it is invasive, so more malignant. And in MRI, which kinetic curve is suggestive of breast cancer? It is the type 3 curve, where you have a wash-in and a washout of the contrast. So that is the type 3 curve which has a wash-in and washout, that is suggestive of breast cancer. And what is the advantage of breast MRI? Also remember that it is the most sensitive investigation for ductal carcinoma in situ. It is the investigation of choice for breast implants as well. That are the applications of breast MRI. Now, if you have a female with breast lump, you do ultrasound and you see that the lesion is showing this posterior acoustic enhancement. What does that imply? That this is a cystic lesion. This is a breast cyst. This is not a solid lesion. This is not a breast cancer. So remember, posterior acoustic enhancement is a cystic lesion. When you have lesion on ultrasound which is hypoechoic, which is wider than taller, on a mammography it has popcorn calcification. It is suggestive of fibroadenoma. Okay, remember that it is suggestive of fibroadenoma. Next one, breast implant patient. The investigation of choice is MRI because of course we cannot do mammography. We cannot compress. It will rupture the breast implant. And MRI is also the investigation of choice to look for recurrence of breast cancer. Now, if there is a breast implant rupture, which could be intracapsular, like within the capsule, or it could be extracapsular. So, intracapsular rupture of the breast implant on MRI shows this linguini sign. The ruptured implant has these membrane sort of thing within the capsule. This is suggestive of intracapsular rupture, linguini sign. This on ultrasound gives the step ladder pattern. The various membranes there give the step ladder pattern. If it is extracapsular rupture, everything going out, so we will see this snowstorm appearance, the silicon going out, that gives the snowstorm appearance. Now coming to testicular imaging, if there is a boy, a male with acute testicular pain, we should always think of a testicular torsion or epididymoorchitis. In epididymoorchitis, because of the inflammation, there would be increased vascularity in the testis and the epididymis. While on the other hand, in torsion, the testicular vascularity would be decreased and we would see this a twisted vascular pedicle, which is called as the whirlpool sign. So remember that for testicular torsion, ovarian torsion, Doppler is the investigation that we need to do to look for this vascularity and the whirlpool sign. So that was about the OBGYN and breast imaging. I hope this is now simplified. Thank you so much.